Hello, everyone. My name is Teresa. I hope everyone's doing well. Thank you so much for coming and joining with me. I'm one of the instructor from Instutor teams. Today, I'm going to discuss about newborn life support. This section is not mainly for Mrcpch, but it's mainly focused on those who are planning to come to the UK and willing to work in NHS. This newborn life support, advanced pediatric life support is actually mandatory. Newborn life support is a mandatory if you have planned to work in the pediatric departments. So I hope that these sections will help you for your preparation for NLS, and I hope that you will join NHS very soon. If you have at any point, if you're not quite clear what I'm saying, just let me know, raise your hands. I'm happy to explain again. So at the end of the station, I'm sure you will be able to differentiate between the physiological difference newborn baby and why we do differently to newborn resuscitation than the adult resuscitations. Also, you will realize, you will know about the process of resuscitations in newborn baby, how to assess the baby at birth, how to resuscitate, some special circumstances of resuscitations. So just before I move to the next stations, I would like to ask that what's the primary cause of cardiac arrest in adult and what's the primary cause of collapse in newborn? Does anyone know that? You can unmute and you can tell me. To be honest, I could not actually see your chart. So I suppose that everyone know that the primary cause of collapse in a death is mainly cardiac events like arrhythmia, asystole. So we focus mainly to get the oxygenated blood enter into the vital center like brain and heart, and we focus mainly on chest compressions in a death. However, in the newborn can survive after newborn get the apnea or hypoxia. The newborn has a reserve like glycogen reserve, so newborn heart is able to beat for approximately 20 minutes after cessations of the breathing. So within that 20 minutes, if we focus on oxygenations and the respiration, I'm sure the oxygenated blood, once oxygenated blood enter into the heart can work properly. So we normally focus mainly on oxygenations in newborn. So that's why in an NLS MCQ, you might probably encounter that, what's main focus for the newborn's resuscitation. The main focus for newborn resuscitation is proper airway opening, airway inflation of the lungs, ventilations of the lungs. In very, very few occasions, we may need to go to the cardiac compression. That case is like when the heart is totally tired and cannot use their glycogen reserve, and that glycogen reserve is almost about to finish, then heart cannot pump properly. In that case, we might need to go on cardiac compression. But most of the time, we just the baby can revive just by simple stimulations or drying the baby can cry and the baby can have a proper APGAR scores and a proper function. And that's actually important because sometime in the MCQ they will probably ask about the percentage, and when you get the NLS booklet, you might probably need to memorize that percentage of babies who recovers after the stimulation, who recovers after the proper airway inflation, and then how many percentage of baby actually need cardiac compression or drug therapies. Very, very low percentage need those cardiac compressions, drug therapies. So that's that. And here it's mentioned like that. Newborn baby will adapt to hypoxic stress because newborn has glycogen reserve in the myocardium, so heart can be able to pump approximately 20 minutes after cessation of the breathing, and also brain can also utilize fuels, alternative fuels like ketones and those kind of things, and that's why the newborn babies can withstand longer period of hypoxia than the adult. And the main difference between newborns and other age is that newborns, the baby immediately after birth, the baby lungs is filled with the fluid, and that is approximately 100 to 120 ml of fluid in the lungs. When the baby passed to the vagina, the normal birth canal, the just only a few amount, like 35% of fluid, get lost with those kind of process. But once the baby start crying, this kind of fluid totally resolve, and also the baby lungs become filled with the air. We call this as the aerations of the lungs. And of course, compared with the adult, in the baby, chest compression is very easy, and the baby chest is compliant with cartilaginous rib cage, and so chest compression is more effective than in adult. But we normally do not need chest compression most of the baby. Is there any questions up to this point? Anyone want to? Okay, so let's move to the another slide. So, what's the physiology of the normal transitions? So we already know that in the mom tummy, in the mom wombs, the baby lens is filled with fluid. So the baby get oxygenated blood from the umbilical vessels, and that oxygenated blood from umbilical vein enter into the right heart, and then to the heart, enter into other part of the body and give oxygenated blood to the body, and then some part of the deoxygenated blood came back from the umbilical artery to the moms, and then gases exchange happen at the placenta circulations. During the labor, because of the changes in terms of the hormones, the fluid secretion cells in the lens stop functioning, and the lens fluid is about to reabsorb. And then also in vagina delivery, small amount of fluid also expelled to the birth canal. And once the baby came out from the moms, the baby start crying, and the crying cause a lot of the pressure, like inspiratory pressure, which is 10 to 15 times greater than that needed in actual life. And that is also important to open the fluid filled lens. And then once the lens has been opened and then oxygenated, the baby start function properly, like with a good oxygenated blood from the lens enter into the heart, and then heart from the heart to the systemic part of the body, and then proper circulations begin. So in here it mentioned that it take approximately 90 to 60 seconds for a healthy teen baby to get a fast breathings, and sometime in healthy baby just skin stimulations or skin coolings can sometimes stimulate the respirations. There is also a criteria that we normally do the delay cord clampings of 60 seconds. Why do we do the delay cord clampings? In a very long times, long years ago, when the baby came out from the moms, we immediately clamp the cord. But after that, we normally do not do like that. We wait for 60 seconds. We call this a deferred cord clamping. What's the advantage of this deferred cord clamping, and why do we consider deferred cord clamping until or unless the baby need immediate resuscitation? Do we have any answer for these questions? Does anyone know that why do we practice deferred cord clamping for 60 seconds? You can chat, or I can see. Why do we know? Does anyone know, right? We normally do not clamp the cord immediately after bed. We wait for the 60 seconds, and then we clamp the cord. Why do we do that deferred cord clamping? And does this has any advantages to the baby? Or what's the advantage? Does anyone know that? Because sometime in MCQ, that kind of knowledge can be tested. So so let me explain to you why the far cord clamping is very essential. So before the baby start crying, the baby lens cannot oxygenate it. So in that case, lens might be still fluid filled, and then oxygenated blood from the lens cannot enter into the heart. So if we immediately clamp the cord, we just Ayla mentioned, I have a question. What are the most effective techniques for clearing the airway in a newborn? That's a very good question. So, in order to clear the airway, in order to clear the fluid from the lungs, the effective techniques is inflations. I'm going to explain to you what is inflations, what is ventilation breath, what is inflation breath. Inflation breaths mean we give the breath with the inspiration times of 2 to 3 seconds, and that push the fluid and that aerate the lungs. That's called inflation breaths. And the proper way to start doing resuscitation is maintain the head neutral positions and then start inflation if the baby is not responsive or not breathing. I'm going to explain that in my later slide, Ayla. So for back to the default clamping, if the baby is not start crying and then we clamp the cord, that's mean we immediately stop the blood flow from the umbilical vessel to the heart. At the same time, because the lens is filled with the fluid, the amount of oxygenated blood from the lens to the heart is not good enough. So that means that the blood cannot pump out properly because it look like we don't have a good cardiac output, and that cause the problems like the child might experience bradycardias. And the advantage of the Farcott clamping is that we just make give the time to the baby for the transition from the fluid filled lens to the air filled lens, and then give the oxygenated blood from the lungs to the heart, and only after that we clamp the cord so we don't find significant changes in terms of baby respirations. And there is also a research regarding what's a good or benefit about delay cord clamping. The benefit is that when we do the delay cord clamping, we reduce the chance of fetal anemia. We also reduce the chance of fetal bradycardia. We also reduce the chance of the increased intraventricular hemorrhage in a baby. I hope that message give you a little bit of idea about why default clamping is important. And there are certain circumstances we do not do the default clamping. What circumstance is that is the baby need immediate resuscitation. The baby is really poor. In that case, we need to clamp the cord immediately. Or sometime, what we do is that we can, if we can take the resuscitate to the near the mom, and then we can resuscitate on the butt of the mom. In that case, we can keep the babies the far cord clamping. But if the baby is really poor, need immediate resuscitation, then we do the delay cord clamping. But at that time, if the baby is not too much preterm, we can still use a cord, milking of the cord, just to get some amount of the blood flow to the heart. So that is the important questions that they can sometimes ask during the MCQ. All right. So let me explain this chart. When you get your NLS booklet, you will find this chart, and this chart is very, very important in terms of the MCQ. They are asking in the NLS and also in the real life situation also. With this chart, you will know that where you are up to. So let's see this chart. It has a few markers like about breathing, oxygen, carbon dioxide, heart rate, and the blood pressure. So what happened is that if the baby have hypoxia, reduce oxygens, the baby can try to breathe, but within a few minutes, like 2 to 3 minutes, if oxygen is still low or baby is still in hypoxic state, the higher center, the brain that control the respiration, called respiratory center, stop working because the brain cannot get enough oxygen, so the brain cannot work properly. So the baby enter into a state called primary apnea. This is a phase where baby is in the primary apnea. In that stage, oxygen is falling, carbon dioxide is rising, heart rate has reduced down to the half of its normal level, but blood pressure is still maintaining, not that much changes. And these kind of primary apneas, it can be present for quite a few times, and after that there is a kind of primitive spinal reflex. We call this primitive spinal reflex produce a gap sim. That gapsin is like shuttering whole body movement, and the breathing rate is 12 per minutes. That's quite important because that can be they can ask that kind of questions. When exactly you might expect primary apnea, and after the primary apnea, how long you expect to see the gapsin, and what is the gapsin? Is gapsin respiration is shallow, or its gapsin respiration is rapid? This kind of thing can ask in the MCQ. And also in the gapsin breathings, the baby breathe approximately at which rate. So you might need to know that it's approximately 12 breaths per minute. So the baby enter into the gapsin stage. And if oxygen is still consistently low and we don't give the oxygen, or we don't correct it, and then the baby enter into the state called terminal apnea. In case of the terminal apnea, oxygen is low, carbon dioxide is still high, heart rate has been very, very low, blood pressure start reducing. And at the time of the terminal apnea, if we do not give any intervention, the baby is probably die within a few minutes. Normally, it take about 20 to 30 minutes for the whole process to finish if we do not do any interventions from the start of the apnea to the terminal apnea. So this is the explanation of the graph that I have just explained to you. So primary apnea means when you have noticed acute hypoxia, the babies start begin to breathe deeply, rapidly. But if oxygen is still fall rapidly, the baby start losing consciousness. Just within 2 to 3 minutes, the baby breathing stop because of the higher center responsible to control the respiratory center is not functioning properly because of the lack of oxygen. The baby enter into a state of primary apnea, and this can be very important. Approximately primary apnea for 5 to 10 minutes. At this time, the blood pressure is still maintained and heart rate has been maintained but can soon fall to the half of its normal rate. Then, after 5 to 10 minutes of primary apnea, if hypoxia still continue, the primitive spinal reflex. Normally, the primitive spinal reflex is inhibited by the higher center. If there hasn't been any inhibition from the higher center, spinal reflex started, then the baby starts shattering with a gapsin with a rate of 12 per minute. There is a question that if the moms is on anesthesias or the moms has been on opioid medications, you might expect to see the longer duration of primary apneic period, and the gapsin period will be a bit reduced. And then after the gapsins, if the hypoxia is still and not correct, then what happens is that the baby respiratory parameter, also metabolic parameter, will become deteriorated. The heart cannot function properly because during the primary apnea or the gapsin phase, even though there is a low oxygen, there is a reserve of glycogen in the heart. The brain can use alternative fuel like ketones or lactate, so they can start. But if it is continue, then this kind of the reserve glycogens or other stuff cannot utilize, and then the baby enter into a state called terminal apnea, and then baby can suddenly die. So what happened if we resuscitate? So there has been the questions that you see the baby has been delivered from the mom, the baby is not breathing. How will you differentiate primary apnea from the terminal apnea? Are you able to differentiate that, oh, this baby is in primary apnea or this baby is in terminal apnea? How will you differentiate? What's the parameter to differentiate between these two? Does anyone know that? So in the booklet, it mentioned that you cannot differentiate between primary and terminal apnea, but there is certain thing you can consider. The baby might be in terminal apnea after you do the resuscitations. So what happened is that if the baby is in the primary apnea, then you can do the resuscitations. So in the resuscitation is just by simply opening the lens or sometime aeration of the lens, because you might see that the heart rate is half and the blood pressure is still maintained. The heart can utilize the glycogen. The heart is still pumping at that time. So you don't need chest compressions. When you give the enough oxygen, The oxygenated blood can go to the heart, so the baby can revive from the primary apnea. So from the primary apnea, it reduce like it go back to the normal breathing, with or without gaps in. But in case of the terminal apnea, you do the resuscitation. Sometimes you might need inflation of the lungs, ventilations, and sometimes the heart is too tired and do not pump probably. You might need to do the chest compressions, and then if you revive the child, then it go to the back sequence, so terminal apnea. And then if it is if the oxygenated blood, if the body get the oxygenated blood again, then the spinal reflex came back, then before you notice the higher center functioning properly. So from the terminal apnea, and you can revive back to the capsin, and then from the capsin to the normal breathings. So it's like backward sequence. So that's why if you do the resuscitation, you've noticed the babies do the capstan and then the baby revive, you might probably think this might be in terminal apnea stage. Um, So, Zunaira, that's a good question. So, when do we do the chest compressions? So, normally after bat, you notice the child is limp. The child has a, very blue color. The child is not responsive, not breathing. What you have to do first is that you just open the clock, make the time, and then you have to first dry the baby, stimulate the baby, and keep the baby head in neutral position. See if the child breathe. If not, the baby is not breathing, not responsive, start inflation the lungs with inflation breath. Inflation breath, as I've mentioned, took 2 to 3 seconds. So it's like 1, 2, 3 is one breath, and then 2, 2, 3 is two breath, 3, 2, 3 that breath, and then 4, 2, 3 fourth breath, and 5, 2, 3 5 breath. So we call this as a 5 inflation breath. So each inflation breath should take 2 to 3 seconds. So we count like 1, 2, 3, and then second breath we count 2, 2, 3. So that's a complete 5 inflation breaths, and then you assess why you are given the inflation breath. You see the baby chest is moving or not. If you notice that the baby chest is moving, that means that you aerate the lungs. The lungs has been aerated. The air is enter into the baby lungs. But if the baby is still not breathing, you assess the heart rate, and if heart rate is low, what you have to do is that you go to the from the inflation breath to the ventilation breath. So ventilation breath, you give approximately 15 breaths, and 1 and 2 and 3 and 4 and 5 and 6 and 7 and like 15 breaths. And then you assess that baby is still not breathing, and then maybe our heart is not pumping properly, like heart rate is very low. You can consider chest compressions after the ventilation breaths of 30 seconds. I hope that answer your questions, but I have another slide, and in that slide you will probably also get an idea about when we do the chest compression. But to be honest, it is in the reality, in the real life, if your airway technique is really good, you won't normally need to do the chest compression. It is very rare to do the chest compressions. I haven't seen any before. Just only good airway techniques is enough. And in the NLS course, they mainly test your techniques in terms of handling the airway, how you give inflation breath and ventilation breath. I hope that answer your questions. Um, suppose that you have got a call from the midwife telling you that, doctor, we have 39.6 weeks ladies with the meconium staying like CTG show fetal bradycardia and distress. We want you to attend the delivery. Okay, so when you get that call, you have to prepare your mind that if you get a call, for example, if you're working in NHS, or if you are about to work in the NHS, you might probably get such a kind of call. Sometime they will give you the call but not giving you the proper explanations of why they want you to attend. In that case, it is your responsibility to ask you about why they want you to attend. So if sometimes some people can call you that, hi, we have a 39 plus 4 weeks in delivery at theater one, can you please come and can you please come to us? So in that case, it is not it is not really good practice for you to just go according to what they mention in the phone. You need to ask them that, tell me what's the risk factor. Would you like my registrar to drive with me? Or what do you anticipate with that delivery? You need to take all the data like gestational age, and then what's the risk factor, and how many people do you want? Do you want consultant or registrar or only me? You need to ask those questions, and then once you prepare mentally from that call, then you go to the operation theater to attend the delivery. Once you reach to the theater, what's your responsibility, what's your task is that first you need to check the equipments, whether the resuscitation equipment is fully facilitated for you or not. So what's the equipment you are expecting? The equipment is you should have a flat surface for the baby to place, radiant heat source heater, dry towel, sections with catheter of at least 12 French, face masks, back and marks, depicts device, the source of oxygen and or air, Gadel airway, laryngoscope with a blade of 0 and 10, nasogastric tube, cord clamp, scissors, trachea tube, umbilical catheterization equipment, adhesive tape, tapes, disposable glove, plastic bag for the if you get a cough that you need to attend the prams of 26 or 28, then there's a need for the plastic bag, and then you must not go that delivery alone as a SHO or junior. You need to ask senior to join with you, because most of the time preterm bags can have a problems with the breathing, so they must probably be with you to support you. And then you must have a saturation monitor and a stethoscope. These are the equipment you need to prepare. And once you have noticed that all the equipments are ready, you need to check the resuscitator has working probably or not. Your TP's device, you need to adjust the pressures of PIMP PIP and PEEP PIP as well. Um, So how will you initially assess the newly born baby? So when the baby is born, just open the clock in the resuscitator and then note the time. And then if the baby is color is pink, good tone, and then the baby is breathing, and so they might probably wait for 60 seconds to clamp the cord, and then they will give the baby back to you. So initial assessment of the baby is like CTBA. Assess the color of the baby, assess the tone of the baby. Is the baby is breathing or not? What's the baby heart rate? That's the initial assessment. I have some YouTube links just to show you that there is a good resource in the YouTube. Like you can check what is the normal baby breathing, what is the gaps in baby breathing, what's the means of respiratory distress baby. So you can also have a look through the YouTube, and so that you get the ideas about what is a pink baby look like, what is a baby with good tone look like, and what's a normal baby breathing look like, or what's abnormal baby breathing look like. If I have a time, we will watch together that YouTube short video about those kind of abnormal baby breathing, so you will get an ideas that, oh, this baby is having gaps in, I need further intervention, or this baby has a normal breathing, I don't need anything else for this baby. And then for the resuscitations, so suppose that the baby is born, the baby is blue, crying a big weak cry or not cry at all, but the baby is still breathing. And so what you have to do first is that just start the clock, put the timer. As soon as they give the baby to you, first of all, dry the baby with the towels, because most of the time, almost all of the time, non-crying baby, the baby who is not crying, usually responds after the skin stimulations with proper drying or skin stimulation. So this is really effective. And then dry the baby just to stimulate. And then what you are drying and then rubbing the back and then stimulate, and the baby is still not crying, you have to open the airway. What you have to do is that keeping the baby positions, the head position in neutral. So what neutral mean is that according to this picture, you know that the baby the face is like a playing playing line position. It's not like a angulated light in two flats or two extended way, just in the horizontal or plane positions like this. So in order to get the neutral position, you can put a roll of the towers into the baby nape of the necks, or sometimes you can do the head lift or chin tip and maintain a neutral positions. So you try the stimulations, you try the drying of the baby is not crying. Then you need to position the baby head in neutral position and see the baby has a respirations, breathings, the baby chest is moving or not. And then if still the baby is not responsive, not crying, the baby chest is not moving, what you have to do is that you need to start giving the breathing, start breathing. So there is a two different type of the breathings. One breathing is called inflation, the other is called ventilations. Inflation means if baby chest is not moving and the baby is not breathing, that means we need to put the air into the baby lungs. That's called aerations. And if you give the aerations, you give the breath, and then you notice the baby chest is moving with your breaths. That means that lungs is filled with air. You don't need to do the air inflation breath again. In that case, if baby is not breathing, like you see, you just check the baby chest, the baby is not breathing, then you have to go on the ventilation breath. Ventilation breath is to get a good oxygenated blood from the lungs to the systemic circulations. So in case of the meconian baby, you go and see the meconian baby. The baby is the babies came out and crying and screaming. You don't need to do anything. Just clean, dry the towel, clamp the cord, give it back to the baby. Screaming baby, crying baby means the baby has open airway. The baby born by meconian like ours, baby is not crying, baby is very floppy. Just follow the standard protocol like ABC. First stimulations and then open the airway and then see if the chest is moving or not with open airway. And then if the chest is not moving, what you have to do is that give inflation breath fast. You don't need to go the section before giving the inflation breath. You just give inflation breath, and if you give the inflation breaths and the chest is not moving, then consider looking to see whether there is any meconian stain like on the mouth obstructing the airway or not. If you have seen any, then do the sections, but you don't need to section first before giving the inflation breaths of meconian stain like us not responsive. So in the bradycardic baby, if the baby is heart rate is low, emphasis is to inflate the lungs and do not inspect anything, do not do anything before you inflate the lungs, before you open the airway, don't do anything. Just open the airway, inflate the lungs, and if you don't see after your inflation breath chest is not moving, then just go and see and then do the sections. So in the breathings, the important parts is that if the heart rate is less than 100 beats per minute or baby is not breathing, then we can go on the ventilation breath. For the breathing, we need to first choose the appropriate size of the mask. Correct size should cover the nose, mouth, and also chins. That should not cover the eyes. And then these are the incorrect position. These are too large and these are too small. So there has been a difference in the pressure we use for the different baby in certain special situations. So for the inflation breaths, we give each inflation breath take 2 to 3 seconds, and then inflation breath is 5 breaths. So one set of inflation breaths is 5 breaths. For example, you just try clean the baby. The baby is not responsive. Open the airway with neutral position or head tension lift, and then you see whether the baby chest is moving or breathing. If not, start inflation breaths. Start with 1, 2, 3. Give inflation 1 breath, and then 2, 2, 3 inflation 2 breath. Then 3, 2, 3 inflation breath, and then 4, 2, 3 inflation breath, and 5, 2, 3 inflation breath. While you are giving the inflation breath, see whether the baby chest is moving or not. If baby chest is not moving, you can give another inflation breath, or in case of the meconium like us, you can suspect whether there has been any obstruction in the airway or not. So you can observe and then quickly do the sections. For the pressure we use for the inflation breath, TEM baby, we normally use peak inspiratory pressure of 30 centimeter water, and preterm baby less than 32 weeks, we use 25 centimeter of PIP, peak inspiratory pressure. So all the baby above 32 weeks, oxygens, we use 21% oxygen or air. Between 28 to 32 week, we use 21 to 30% of oxygens. And at 28 weeks, we give 30% of oxygens. For the PEEP, if you are using TP's device, then your TP's device will have PEEP system. PEEP is you set every children at 5 centimeter water. Okay, so you give the inflation breath, 5 inflation breaths, see if baby is response or not. So when you give 5 inflation breaths, you check the heart rate. Heart rate is increasing. If chest wall is rising during the inflation breaths, and then you see the heart rate is increasing, however, the baby is still not breathing, then you go to the ventilation breaths. So ventilation breath is 30 breaths per minute. So 1 minute, 30 breaths. So we give the ventilation breath 30 seconds. So 30 seconds means we give 15 breaths, and then we reassess whether the baby's heart rate is improving after the ventilation breaths or not. Okay, so if your ventilation is adequate, the heart rate will remain above 100%. And it is, if your ventilation is not adequate, then the heart rate will start falling. So in that case, check your airway position again, check your ventilation techniques, and then go on the ventilation breaths again. I got it, chat. Inflation breath by back or marks. So if you are using the back and marks, you can use that with the back and marks. But here they use a TP's device. So with the, have you ever seen any TP's device? So in the YouTube, you can check TP's device is like small little tubes where there has been an occlusion over the top, and then when you occlude it, and then when you re-occlude it, you give the breath to the baby. For the inflation breaths, you can give by back and marks as well in case of the resource limiting settings. Yeah. So you give 5 inflation breaths, the baby chest is moving and the baby heart rate is increasing. However, baby is not breathing. So do the ventilation breath. While you are giving the good ventilation breath, baby heart rate should maintain at 100. However, at some point, if heart rate is reduced down to the 100, check your techniques of ventilation, check your airway position techniques. Okay. If the heart rate is not increasing, so you give 5 inflation breath, the chest is moving. However, if the heart rate is not increasing, the most likely cause is that you are not giving proper inflation breaths. Look like you are not aerated the lungs properly. So reassess, is the chest is moving with your inflation breaths or not. If your heart rate is not responsive, see the chest move as you give the inflation breaths is the only way to judge. So if you give the inflation breath, the heart rate is not improving. And let's see whether your chest is moving. If your chest is not moving, go to the inflation breaths, check the airway, go to inflation breaths. However, if the chest is moving, but heart rate is not responsive, then what you have to do is that go to the ventilation breaths of 30 seconds, that is 15 breaths. Then reassess. After you reassess, the heart rate is still slow despite adequate ventilation breaths for 30 seconds, then you start the chest compressions. Once you start the chest compressions, increase your oxygen to 100%. What we are doing is that we are giving the oxygen to the TEM baby with the 21% oxygen, brand around 21 to 30% oxygen. However, if you start the chest compression, your oxygen should increase to the 100%. Am I making myself clear, or is there any question at this point? I'm sure it might be a bit confusing. So just make the algorithm in your mind that you start giving inflation breaths, you see the baby chest is moving, and you assess the heart rate. The heart rate is more than 100. However, the baby is not breathing. What you have to do is that give ventilation breaths. If you give a good ventilation breath, probably the heart rate is still maintaining above 100%, and maybe the baby will have a breathings after you have enough ventilation breaths for the baby. However, while you are giving ventilation breaths, you've noticed the heart rate is decline from the 100 down to the 60 or 80. Then you consider whether my airway is still patent or whether my ventilation technique is still good or not. And then you just check the airway. And in case you need the changes, just make the changes just to get the good ventilation. However, you give the ventilation of if you give the 5 inflation breaths, you see the chest wall movement. However, you don't see the appropriate good heart rate response. The heart rate is still less than 60. You go to the ventilation breath. Even if baby is breathing, you go to the ventilation breath. After you give ventilation breaths of 30 seconds, which is 15 breaths, you assess the heart rate again. If the heart rate is still not responsive, the baby chest is moving, baby is breathing, then you have to go to the chest compressions, and during that time increase the oxygen to 100%. So for the chest compressions, there is certain things you need to know. That chest compression to ventilation ratio. Uh, so chest compression to ventilation ratio in the newborn baby, it is 3:1. In older children, it is 15:2, and then in adult, it is 30, right? 30:2. So it's quite difference between the chest compression to ventilation ratio, newborn baby. Newborn baby, we give 1, 2, 3, and then breath. 1, 2, 3, and then breath. Because we want to give oxygen more to the newborn baby rather to the adult or to the children. So where primary cause of the problems in newborn is the airway. So the rate, they can ask you the rate of about every 15 cycles every 30 seconds. So normal techniques, the most the popular techniques is a two-hand techniques to compress the chest. You need to check for the response every 30 seconds. While you are doing chest compressions, increase your oxygen to 100%. The place where you put your hand is just below the imaginary line joining the nipple, and then it should go to the depth of a that. And then rate is 90 compression, 30 breath in a 1 minute. You can find that kind of questions in your MCQ paper. So these are the important notes I have taken for your MCQ purpose and also for your real life as well. So let's look to the algorithms, and just to make sure that we are on tracks with what we have discussed today. You got a call that the midwife told you there is a baby, 34-week preterm baby, about to get delivered. So what you have to do fast is, if the baby is born very preterm, like 28, 26, or 32, you need antenatal counseling. You need to explain what might going to happen with the child just before the delivery start, or once a pregnant lady start admitted. And then if the baby, if the woman is in the labor, then you need to start with equipment check. Then make sure that there is a delay clamping if possible. And then the baby once the baby is born, put the clock, note the time. Important part, dry the baby, wrap in a towel, and then stimulate, keep warm, and then assess baby color, tone, breathing, heart rate. If the baby is not responsive, not breathing, you don't notice any chest wall movement, open the airway, or in head, did, chin lift, or jaw thrust. And then if the baby with the open airway, baby is not breathing, the baby chest is not moving, start with the inflation breaths, 5 inflation breaths. Now, if you notice the baby is gasping, then do the 5 inflation breaths. Pressure is 30 centimeter water. For the term baby, preterm baby is 25 centimeter water. PEEP is always 5 centimeter water. And then you reassess after you give the 5 inflation breaths. There is no chest wall movements, so give another rounds of inflation breaths. If there is a chest wall movements, or if there is a chest wall movement, you assess the heart rate. If heart rate is low, go to the ventilation breath. If heart rate is good but baby is not breathing, then go to the ventilation breath. If you notice the chest is moving, heart rate is increasing, and if you notice that the chest is moving, the baby is breathing but heart rate is not enough, give ventilation breath, reassess 30 seconds. If after the 30 second baby is breathing, chest is moving but still heart rate is less than 60 seconds, then try chest compression 3:1 with oxygen of 100%, and then reassess after 30 seconds. Is still heart rate is less than 60, considers giving the vascular access or drugs, and but it is very rare to go that side. There is also kind of MCQ. They will ask you that you can expect the baby oxygen at 2 minutes around 60. At 5 minutes, the baby oxygen, preductal oxygen is 85%. 10 minutes is 90%. So do not get panic. You do the baby, you check the baby oxygen at 2 minutes of life, and you have noticed the baby oxygen is 60 minutes. Do not get panics and don't think that the baby need a vigorous amount of oxygen. No, this is normal for that time of the 2 minutes of age. So only you check that baby oxygens at 5 minutes and baby oxygen is less than 80, then you need to consider whether you need to give the oxygen, good amount of oxygen. Always use always use oxygen judiciously, because hyperoxemia can also have risk to the baby. And also maintain the temperature of the newborn baby around 36.5 to 37.5, which is very important, because every 1 degree Celsius temperature fall down, there is an increased risk of mortality to 28%, which is quite a good questions they can ask in their theory test. I hope that these lectures would cover some part of the neonatal life supports. I'm sure that I might not cover almost all. There are so many others in the booklet you need to read. What I can suggest you is that if you are preparing for the NLS course, read the booklet thoroughly, because most of the MCQ and quiz are mainly the factual things like how many percentage, how many at which minutes the gaps in labs, for how many breaths per minute is gaps in, is those kind of thing. So until or unless you thoroughly read that book, like, you might not be possible to pass the theory exam. I hope that give you at least a brief idea about what is NLS and how you might expect if you have noticed the emergency case in the newborns. Is there any other questions? I think I have just finished. See. uh Booklets is that I will try to share to the Met Institute teams, but this is a copyright purpose, so I cannot share the UK the Registration Council new UK booklet. I don't have a PDF or scan file, and this is also against a copyright rule. So but I have a kind of Americans registrations or other booklets, so I can share those with you. You can have a read.
Okay. Okay. Thank you. Thank you so much.
You're welcome. Any other questions?
Much, ma'am, for the lovely session. Hope to see you again.
Pardon, what did you say? I'm sorry, I couldn't hear very well.
Thank you so much, ma'am, for the lovely session.
All right, okay, thank you. So if there
Okay.
isn't any questions, would you guys want to watch the YouTube video about the Gapsin baby, or would that be all right that we stop our section today?